This recorded lecture will be going over Chapter 28, The Child with a Gastrointestinal Condition. The anatomy of the digestive tract, with some of the differences between that of the child and the adult, is depicted in Figure 28.1 on page 659. As the child grows, the GI capacity increases. There are 4 types of endoscopy typically used in pediatrics that will allow for the direct visualization of the GI tract. Capsule endoscopy requires the child to swallow a capsule that contains a camera, which then takes pictures as it passes through the GI tract propelled by natural peristalsis. Nursing responsibilities include assisting with the diet and bowel cleansing the day before, documenting the passage of the capsule if noted. For more detailed information concerning preparation for various tests, you can refer to a laboratory diagnostics textbook. Symptoms of GI disorders may be manifested by systemic signs, like failure to thrive or jaundice. General nursing interventions will focus on providing adequate nutrition and freedom from infection, which can result from malnutrition or depressed immune function. Developmental delays in children should be investigated to determine whether they are related to the GI system. Atresia of the esophagus is caused by a failure of the tissues of the GI tract to separate properly from the respiratory tract early in prenatal life. There are 4 types of TEF, and you can see these on page 660, as well as some pictures in Figure 28.2. The earliest sign of TEF occurs prenatally when the mother develops polyhydramnios. After birth, the infant will vomit and choke when the first feeding is introduced. Because the upper end of the esophagus ends in a blind pouch, the newborn cannot swallow accumulated secretions and will appear to be drooling. Abdominal distension is another sign. The nursing goals involve preventing pneumonia, choking, and apnea in the newborn. Assessment of every newborn during the first feeding is essential. Surgical repair is essential for survival. An imperforate anus occurs when the lower end of the GI tract and the anus end in blind pouches. Failure to pass meconium within the first 24 hours must be reported. Infants should not be discharged to home before a meconium stool is passed. After a diagnosis of imperforate anus is established, the infant is given nothing by mouth and prepared for surgery. Diagnosis will be confirmed by X-ray study or MRI. Pyloric stenosis is an obstruction at the lower end of the stomach caused by an overgrowth of the circular muscles of the pylorus or by spasms of the sphincter. Symptoms do not appear until the infant is 2 or 3 weeks old. Vomiting is the outstanding symptom of this disorder. Typically, projectile vomiting occurs after feeding. Dehydration as well as malnutrition can develop. An olive-shaped mass may be felt in the right upper quadrant of the abdomen. The surgery performed for pyloric stenosis is called a pyloromyotomy. This is also known as the Ramstead surgery and involves cutting into the hypertrophied muscle but not through the mucous membrane of the bowel. The dehydrated infant is given IV fluids preoperatively to restore fluid and electrolyte balance. The infant is burped before as well as during feedings to remove any gas accumulated in the stomach. The nurse also notes whether the infant appeared hungry after the feeding or if vomiting occurred again. Position is changed frequently because the infant is weak and vulnerable to pneumonia. Overfeeding is avoided, and the nurse reviews feeding techniques with the parents. Celiac disease is also known as gluten enteropathy and sprue. It is the leading malabsorption problem in children. This is an autoimmune genetic illness that affects the small intestine due to gluten intolerance and resolves with the removal of gluten from the diet. Symptoms are not evident until the infant is 6 months to 2 years of age, when food containing gluten are introduced. The infant will present with failure to thrive. Diagnosis can be confirmed by a serum immunoglobulin A, anti-gliadin antibody, anti-tissue transglutaminase, and an increased fecal fat content. The characteristic profile of a child with a malabsorption syndrome is abdominal distension with atrophy of the buttocks. Celiac disease can be classified into 4 types, and you can read about these on page 664. The treatment for celiac disease involves a lifelong diet with restrictions on wheat, barley, and rye. A professional nutritionist or dietitian can aid in identifying foods that are gluten-free. Hirschsprung's disease, or aganglionic megacolon, occurs when there is an absence of ganglionic innervation to the muscle of a segment of the bowel. There is a lack of normal peristaltis, resulting in chronic constipation. In the infant, constipation, ribbon-like stools, and abdominal distension, anorexia, vomiting, and failure to thrive may be evident. Megacolon is treated by surgery. Nursing care will be age-dependent. When a child is given an enema at home, normal saline solution, not tap water, must be used. The nurse must stress this to the parents, the importance of using the saline solution. Intussusception is a slipping of one part of the intestine into another part just below it. Edema will occur. Occasionally, the condition will correct itself without treatment. The prognosis is typically good when the patient is treated within 24 hours. In typical cases, the onset is sudden. The infant feels severe paroxysmal pain in the abdomen, as evidenced by loud cries, straining efforts, and kicking and drawing of the legs towards the abdomen. At first, the child will vomit. Little flatus is passed. Movement of blood and mucus will contain no feces are common, and these are known as currant jelly stools. Intussusception is an emergency, and because of the severity of symptoms, most parents will contact a healthcare provider promptly. An ultrasound-guided hydrostatic reduction is the treatment of choice, with surgery scheduled if reduction is not achieved. During fetal life, the intestine is attached to the yolk sac by the Vitelline duct. A small blind pouch may form if this duct fails to disappear completely. This condition is termed Meckel's diverticulum. Symptoms may occur at any age, but appear most often before 2 years of age. Painless bleeding from the rectum is the most common sign. The diverticulum is removed by surgery, and emotional support is of particular importance. An inguinal hernia is a protrusion of part of the abdomen, part of the abdominal contents through the inguinal canal in the groin. It is also commonly seen in preterm infants. An umbilical hernia is a protrusion of a portion of the intestine through the umbilical ring. Hernias could be present at birth or may be acquired, and they can vary in size. An incarcerated hernia is a hernia that is irreducible and cannot be pushed back into its place by gentle pressure. The infant with a hernia must be relatively free of symptoms. Irritability may be relatively free of symptoms. Irritability, fretfulness, and constipation are sometimes evident. A strangulated hernia occurs when the intestine becomes caught in the passage and blood supply is diminished. Vomiting and severe abdominal pain are present. Emergency surgery is necessary if strangulation occurs, and in some cases a bowel resection is performed. Hernias are successfully repaired by the surgical operation called a herniorrhaphy. Gastroenteritis involves an inflammation of the stomach and intestines. Colitis involves an inflammation of the colon. Enterocolitis involves an inflammation of the colon and the small intestine. The priority problem in diarrhea is fluid and electrolyte imbalance and the failure to thrive. Treatment of motility disorders is focused on identifying and eradicating the cause. Nursing responsibilities include teaching parents and caregivers proper and age-appropriate diet and feeding techniques. The nursing care of gastroenteritis includes maintaining intake and output records and providing skin care and frequent diaper changes to prevent excoriation from the frequent stools. The infant should be weighed daily. Table 28.1 will list some of the terms that often need clarification for the parents of a child who is food intolerant. You can see this on page 667. Vomiting is a common symptom during infancy and childhood. Persistent vomiting will require investigation because it results in dehydration and electrolyte imbalance. The child may vomit for various reasons. Aspiration pneumonia is a serious complication of vomiting. To prevent vomiting, the nurse must carefully Feed and burp the infant. To prevent aspiration of vomitus, the nurse places the infant on the right side following feedings. IV fluids may be given. Oral fluids should be withheld for a short time to allow the stomach to rest. Gastroesophageal reflux will result when the lower esophageal sphincter is relaxed or not competent, allowing stomach contents to be easily regurgitated into the esophagus. Symptoms include vomiting, weight loss, and failure to thrive. Of particular interest is when the vomiting started, type of formula, type of vomiting, feeding techniques, and the infant's eating in general. Prolonged esophageal pH monitoring is one of the most definitive diagnostic tests. Therapy will depend on the severity of symptoms. Parents are instructed to burp the infant frequently. After being fed, the infant should be placed in an upright position or propped on the left side. The upright prone position has been recommended for the infant with GERD when awake and being monitored. A proton pump inhibitor like Prilosec and chronic antacid therapy should be avoided. Diarrhea in the infant cannot be defined in the same way as diarrhea in the adult. Diarrhea in infancy is a sudden increase in stools that differ from the infant's normal pattern. The symptoms of diarrhea could be mild or extremely severe. The infant could become listless, refuse to eat, and lose weight. Dehydration will be evident. Infectious diarrhea in infants is commonly caused by the rotavirus that occurs often in daycare centers. Prevention is important and will center around teaching the basics of hygienic practices, hand washing, and the use of disinfectants. Treatment is essentially the same. Reducing the intake of solid foods will allow the intestine to rest. Oral rehydration solutions like Pedialyte or Infolite in liquid or frozen ice pop form are preferred, with the gradual introduction of a soft, bland diet. Nursing Care Plan 28.1 will provide nursing interventions for the care of a child with diarrhea. The frequency of bowel movements will vary widely in children. Constipation could be a symptom of other disorders, particularly obstructive conditions. Diet, culture, and social, psychological, and familial patterns could also influence its occurrence. Evaluation begins with a thorough history of dietary and bowel habits. Parent teaching concerning the prevention of constipation is essential. Dietary modifications include adding more roughage to the diet. Increasing fluid intake is also important. The use of stool softeners, fluids, diet, and behavior modification can prevent a chronic functional constipation problem from occurring. Infants and small children have different proportions of body water and body fat than adults do, and the water needs and water losses of the infant are greater. In children younger than 2 years of age, surface area is particularly important in fluid and electrolyte balance because more water is lost through the skin than through the kidneys. Fluid turnover is rapid, and dehydration occurs more quickly in infants than in adults. They are less able to concentrate their urine. Signs of dehydration in a child may not be evident until the fluid loss reaches 4%, and severe dehydration may not be evident until the fluid loss reaches 10%. Oral rehydrating solution alternatives like Pedialyte or Infolite are preferred to IV therapy. Toddlers and infants are not capable of drinking by themselves. Brightly colored containers and drinking straws can help. The nurse keeps an accurate record of the patient's intake and output. Fluids with a high glucose or sodium content, like colas and juices, should not be used. Parenteral fluids are necessary when vomiting or loss of consciousness accompanies sickness or when the GI system requires rest. The infant or child receiving parenteral fluids needs the nurse's warmth and affection. Arm boards can prevent the child from pulling out the IV line and protect the tubing. Dehydration occurs whenever fluid output exceeds fluid intake, regardless of the cause. Disorders of fluids and electrolytes are more complex in growing children. The younger the patient, the higher the metabolic rate, and the more unstable the heat-regulating mechanisms. The average urine output in infants and children can be shown on Table 28.3 on page 674. It is an important nursing responsibility to document the intake and output of hospitalized infants and children. Life-threatening deficits can ensue within a few hours. And you can read more about this on page 674 within Table 28.4. Problems of fluid and electrolyte disturbance will require evaluation of the type and severity of dehydration, clinical observation of the patient, and the chemical analysis of the blood. See Table 28.2 for more information on isotonic, hypertonic, and hypotonic fluids and dehydration. Maintenance fluid therapy will replace normal water and electrolyte losses, and deficit therapy will restore pre-existing body fluid and electrolyte deficiencies. It is important to know the composition of IV fluids and the amount and rate of flow in order to prevent complications. Potassium is lost in almost all degrees of dehydration. Replacement potassium is administered only after normal urinary excretion is confirmed. Edema is the presence of excess fluid in the interstitial spaces. Any factor causing sodium retention can cause edema. Low protein levels can also disturb osmotic cellular pressure, causing edema. Trauma to or infections of the head can cause cerebral edema, which can be life-threatening. Anasarca is a severe generalized edema. Edema in infants may be first seen around the eyes and in the presacral, occipital, and genital areas. Early detection and management of edema are essential. The nurse must be able to assess the electrolyte needs of the child, and you can see this in Table 28.5 on page 675. It is a nursing responsibility to correlate laboratory findings of the individual child with fluids and foods that are offered to the child. Failure to thrive describes infants and children who, without an obvious cause, fail to gain and often lose weight. Infants who fail to thrive are often admitted to the hospital for evaluation, with presenting symptoms of weight loss or failure to gain, irritability, and disturbances of food intake, such as anorexia or pica. Development is delayed. The child has a complete workup to identify organic reasons for FTT, and the cause is treated. Infants will suffer from the inability to establish a sense of trust in their caregivers. Obvious neglect and physical abuse are not uncommon. Treatment involves a multidisciplinary approach in accordance with the circumstances. During hospitalization, one nurse per shift is selected to increase nurturing and interaction with the infant and parent. It is vital to support rather than reject the mother. The nurse should encourage her to assist with the daily care of her child. The prognosis of this condition is uncertain. Kwashiorkor is a protein deficiency. In kwashiorkor, there is a severe deficiency of protein in the diet, despite the fact that the number of calories consumed may be nearly adequate. Kwashiorkor occurs in children 1 to 4 years of age who have been weaned from the breast. The child fails to grow normally. The muscles become weak and wasted. There is edema of the abdomen that may become generalized. Diarrhea, skin infections, irritability, anorexia, and vomiting may be present. The earliest sign of this protein malnutrition is a white streak in the hair of the child, known as depigmentation. Treatment for kwashiorkor is mainly preventative. Rickets is a disease of infancy and childhood caused by deficient amounts of vitamin D. The classic symptoms of rickets are bow legs, knock knees, beating of the ribs, called ricketic rosary, and improper formation of the teeth. The nurse should guide parents concerning the need for an optimal, well-balanced diet, exercise, and exposure to outdoor sunlight. Scurvy is a disease caused by insufficient fruits and vegetables that contain vitamin C in the diet. The symptoms of scurvy include joint pains, bleeding gums, loose teeth, and lack of energy. The vitamin is not stored in the body, and daily intake from food sources is required. The most common reason for emergency abdominal surgery in childhood is appendicitis. A delay in diagnosis often occurs because the younger child is unable to localize or express the symptoms experienced. Therefore, the incidence of ruptured appendix is high in young children and after 12 days of symptoms. Vomiting can occur after periumbilical pain starts. Fever is not a reliable sign of appendicitis in children. On examination, characteristic tenderness in the right lower quadrant, known as McBurney's point, will occur. Other diagnostic signs will include the following: guarding, rebound tenderness, pain on lifting the thigh while in the supine position, and pain in the right lower quadrant when palpated. A CT scan with rectal contrast is administered via the rectum to confirm the enlarged appendix. Signs of ruptured appendix and peritonitis include sudden relief of acute pain, rigid guarding of the abdomen, abdominal distension, tachycardia, chills, and irritability. A warm stethoscope should be used when auscultating the abdomen of a child. It is less frightening than the approaching fingers of the hand. The nurse should explain what to expect, discuss coping mechanisms, and provide referrals as necessary. Pain management, prevention of infection, and early ambulation are the primary goals. Thrush is an infection of the mucous membranes of the mouth caused by the fungus Candida. The mucous membranes of the infant's mouth can become infected by direct contact with this infection during delivery or by contact with the mother's or nurse's contaminated hands. White patches that resemble milk curds appear on the tongue, inner lips, gums, and oral mucosa. A thrush infection responds well to the local application of an antifungal suspension, such as nystatin. With proper care, the condition will disappear within a few days after its onset. Disposable bottles or pre-filled formula bottles are used. Disposable nipples, pacifiers, and bottles are preferred. The main nursing responsibility is the education of the patient and family concerning the prevention of worm infestation through general hygiene, food handling, and environmental controls. One of the several varieties of worms that affect humans, the most common is the pinworm. It is seen more often in toddlers, but it can develop in older children and adults. The nurse or parent may notice that the child scratches the anal area and may complain of itching. Weight loss, poor appetite, and fretfulness during the night can develop. Several effective antihelminthics are available. The child must be taught to wash the hands thoroughly after bowel movements. All symptomatic members of the family should be treated for this condition to prevent reinfection. The toilet seats in the home should be scrubbed daily. Ascaris lumbricoides is a roundworm. An infestation can be asymptomatic or cause abdominal pain. The child will ingest eggs from contaminated soil. A chronic cough without fever is characteristic of this condition. Prompt and early treatment is recommended. Poisoning is the #1 cause of accidental death in the United States and the third leading cause of accidental deaths in adolescents. Goals in the primary management of poisoning include removing access to the poison, preventing further absorption, calling the Poison Control Center, and providing supportive care and seeking medical help. Treatment of poisoning includes the prevention of absorption, enhancement of the excretion of the poison from the body, maintenance of fluid and electrolyte balance, and cardiopulmonary stabilization. A child aged 2 to 3 years who takes one swallow may have ingested about 3 milliliters of poison. Education of parents and children is the best way to prevent poisoning. The telephone number of the Poison Control Center is listed in the telephone directory and should be posted near the phone. Parents are advised to call the Poison Control Center and bring the container of the substance ingested to the hospital emergency department as quickly as possible. Table 28.6 on page 680 will indicate how to assess the type of toxic substance ingested according to the smell of the vomitus. Activated charcoal provides a large absorptive area that combines with many toxins in the stomach to prevent absorption and facilitate excretion from the body. Many children will vomit after receiving a dose, so this should not be used after ingestion of a caustic substance. Activated charcoal must be administered within 1 hour of ingestion in order for it to be effective. Gastric lavage is rarely effective more than 1 hour after the ingestion. It is no longer recommended as a routine treatment for poisoning. Whole bowel irrigation involves instilling large volumes of polyethylene glycol electrolyte solution to flush the entire GI tract. Enhanced elimination of toxins can be used if a toxin is already absorbed in the body and may prevent organ damage. Techniques include the following: alkalization of the urine, hemodialysis, peritoneal dialysis, and intralipid emulsion treatment. Drugs prescribed for family members and left within the reach of children are often the cause of accidental poisoning. Many over-the-counter medications are considered harmless by parents, but could be deadly to toddlers, even in small doses. You could read about some of these on page 681 within table 28.7. Common antidotes for specific poisonings are also listed in box 28.1 on page 681. Common household plants that are poisonous are listed in the green health promotion box on page 681. Acetaminophen has now replaced aspirin as the most commonly ingested drug that causes toxicity. Nursing responsibilities for patients with acute poisonings are shown in table 28.8 on page 682. Medical intervention is necessary if the single ingested dose exceeds 200 milligrams per kilogram per day. Treatment should be started within 24 hours of ingestion. NSAID overdose symptoms can include GI irritation, reduced kidney function, and platelet dysfunction. Treatment includes medications that reduce stomach acids, as well as supportive therapy. In aspirin poisoning, even a dose as small as 1 teaspoon could cause a child's death. Salicylate acts rapidly but is excreted slowly. It is wise to read labels carefully and to administer aspirin slowly. Nausea, vomiting, ringing in the ears, and tachycardia are all symptoms of overdose, and seeking medical intervention as soon as possible is essential. Lead poisoning, also known as plumbism, results when a child repeatedly ingests or absorbs substances containing lead. Lead poisoning is most common in children between 18 months and 3 years of age. Lead is a neurotoxin and can have lasting effects on the nervous system, especially the brain. The symptoms occur gradually and range from mild to severe. In the beginning, signs include weakness, weight loss, anorexia, pallor, irritability, vomiting, abdominal pain, and constipation. In later stages, signs of anemia and nervous system involvement, such as muscular incoordination, neuritis, convulsions, and encephalitis, are observed. Treatment is aimed at reducing the concentration of lead in the tissues and blood. Chelating agents combined with lead in the blood can safely excrete them from the body. The prognosis will depend on the extent of poisoning. Prevention of this condition is of foremost importance. Approximately 80% of all foreign body ingestion occurs in children between 6 months and 3 years of age. Unless the object is sharp or large, passage through the GI tract may be possible and can take up to 4 to 6 days. Parents should be instructed to notify the healthcare provider if abdominal pain or vomiting occurs.